and we're very glad to welcome all of you to today's CMDA monthly meeting. I am Sing Pallet, the president of CMDA, joined today by Val Shade and Chris Horton, who we'll all be hosting today's meeting. Today we have Jenny Albertson starting us off with updates from CHCA. Jenny's ready to go, so why don't I let you have the floor, Jenny?
Good morning, everyone. Thank you for hosting me. My name is Jenny Albertson. I'm the Director of Quality and Regulatory Affairs at the Colorado Healthcare Association. So in case you're not familiar and why we get a piece of the floor here at your CMDA meetings, we collaborate closely with CMDA because we are of like interest. Our association is the trade association for all nursing homes and a third of the assisted living beds in the state of Colorado. So we do advocacy and support, and I am on the education side. So I was a nursing home administrator running buildings alongside medical directors for 20 years. And so I try to keep you informed with things that I know that you will be interested in. First off, of course, we all want to know what our funding stream is going to look like given the budget discussions. So here's an update on Medicaid. We have a small victory so far. We've overcome the first and largest hurdle in preserving our Medicaid funding for long-term care. We are hopeful at this point that we will retain our 1.5% year-over-year increase, which is simply meant to pad the blow of inflation a little bit. We knew we were not going to get a broader increase, but we were very fearful that we might get a cut completely, even below our existing reimbursement, which is only 80 to 85% of cost that we exert for our Medicaid folks. So it's passed the Joint Budget Committee for us to retain the 1.5% increase. Now we have to go through the House and Senate for full approval. And just so you know why this was in question beyond the federal dialogue about trying to cut Medicaid funding at the national level, we at our state level are dealing with a $1.2 billion budgetary shortfall, and they're trying to make all of that gel without cutting things like Medicaid. That's been kind of a sacred cow, actually, which is lovely to have us be preserved with everyone at our back. In other news on the national level, you've probably heard of this, but I wanted to clarify how this might impact long-term care. CMS and Health and Human Services more broadly are doing a very significant reorganization under the new HHS Secretary, RFK Jr. They're reducing the number of employees by nearly a quarter. And at CMS, they are cutting, page up, sorry. They're cutting things that are around troubleshooting and Medicare beneficiary benefits, Affordable Care Act advocacy, that sort of thing. So I'm assuming we're going to see some downstream effects. In other news, with that cut, they are eliminating some agencies entirely and consolidating others together. So these are ones that I think will most definitely impact us directly. One is the Substance Abuse and Mental Health Service Administration, SAMHSA, which you'll see referenced throughout the surveyor guidance. They administer the 811 hotline. And so they also provide us direct guidance on how to deal with substance abuse within nursing home settings. And we had a benefit given to us under CMS for us to have this direct line for case management advice and care planning for those with substance abuse disorder. So that is going away. Also, the Administration for Strategic Preparedness and Response is moving completely under the CDC. So that includes our pandemic response. So that office is being disbanded and many of its functions. And then probably the most impactful is our Administration for Community Living is being basically eliminated. They're managing most federal supports other than Medicaid and subsidized housing for people that fall under the older adult category that are living in non-institutionalized settings. So we care about this because of transitions of care, and also because we're going to see people coming to us in a less healthy fashion, having not received benefits along the way. So this includes Meals on Wheels, adult day programs, area agencies on aging, falls and elder abuse prevention programs, and respite care. All of those are being eliminated on a federal support level, and they will be relegated to private business and state level funding entirely. This is a bit shocking. The links to more detail are in the microscopic print at the bottom of the slides, and you will be receiving these. And then along with these eliminations, they have frozen our civil money penalty grant program. So they just put out a request for applications probably a week before the announcement that said, hold please, CMS is not administering any programs outside of what's absolutely bare minimum necessary right now. So that's where we stand. Any questions?
Jenny, so area agencies, Dr. Cog is no longer going to receive any federal funding?
That is, as I understand it, it is one of the programs that's being wholesale eliminated.
Okay, I was going to say thank you, but that seems like a weird response. So,
yeah, thank you, sir. May I have another, more like? This is all very shocking, and I understand that I'm bearing some very hard to stomach news, and it seems kind of like, what do you do to contextualize this? We really don't know what we do to contextualize it yet. It's a very big unknown.
Just something that, like, if we had time to hop onto and you hadn't come down, I just was like, oh, I'll just get on there.
Oh, Melissa, are you making a comment for us? That might have been for someone else. But thank you, Jenny. It's always hard to hear news like that, but we appreciate being up to date. And we definitely look forward to seeing how you and how CHCA will be responding, and let us know what we can do to help.
Yeah, I think the message underlying this for me, as I'm sitting as an administrator and looking at your faces, is that the elders we support are going to rely far more heavily on us for what they need. And I'm pleased that those around us are as competent as they are. We may want more support than we will have to do that work, but we should take the mantle because we have the passion.
Oh, great. Thank you very much. Yep. And when you share your slides, I'll be happy to share them with all of CMDA. Thank you. Well, Chad Fear is on the call from CDPHE. Hello, Chad.
Hello to you and everybody. Gosh, Jenny, learning.
Did Chad freeze just for me or for everyone?
He's
Pardon?
frozen.
Oh, you froze for a moment there, but I think you're back, Chad.
Oh, it's post-COVID. That must be what it is. But so from the discussion that I brought to last month's meeting, we talked about some of the changes that are up and coming for the now April 28th planned revisions to implementation of the planned revisions to the state operations manual. And I had a PowerPoint that I shared with the Nursing Home Roundtable in March, and I've not yet released that to everybody because I'm working on updates to the PowerPoint and the information that's included in that. So the information really hasn't changed, but we've continued to receive updates to the process for survey and receive more clarification to those regulatory changes. And the one thing that I do want to point out as it would affect this group and other medical directors is in the survey process. It really ensures the conversation between the surveyor and the medical director as it pertains to some of those very specific areas. The quality assurance process, the review of unnecessary psychotropic medications, to name a few of those areas. So as I get that completed, since I already have a framework for that information, I'll continue to add that to that PowerPoint. I will send that out through the portal, but I will also provide that to you all for dissemination, so that everybody has kind of the same information that we're looking at. And you can look at the memos and you can see for yourself what some of those changes are. But again, it's I think a lot of that has to do with the we talk to our surveyors all the time. We have regulation, and then we have survey process. And I think a lot of what we are working through is what that survey process will and should look like. One of the things that we work very hard with our surveyors is, not taking something at face value. And it really should be our obligation in our collaboration together to fully understand a situation. So I think some of these changes, while they may appear daunting on the surface, should actually serve to help help us to evolve within the survey process and to ensure that communication, that asking another 2 or 3 questions may provide clarity as to the circumstances. And the regulations are in black and white, but when you apply the individual and the individual situations to those those specific instances, I think there's more for us to know. And it really is fully our responsibility to, no matter what the outcome is of our investigation, that we are accurate and that we're getting the findings correct. Because at the end of the day, as Jenny said, it really is going to fall on us to ensure that our population is getting the care that they need. And while our role in that process is a little bit different than the role that y'all may fill, I think we still must collaborate together to provide the best care across our industry here in Colorado. So that's our commitment. Again, it's about understanding that information, understanding the survey process, and then sharing it with all with you, so that we are all ultimately on the same page as much as we can be with, again, the information and the process. So that's really what I have for y'all today. If there are any questions, I'd be happy to take them. And if not, please look soon for the updated information that I will be able to share.
Thank you, Chad. I love how your message is always so collaborative. We're always glad to have the surveyors on this call with us, as well as at our upcoming CMDA annual conference. If you haven't registered, we're going to be pushing this pretty heavily over the next couple of weeks. But thank you to the CDPHE for coming to this conference, and it's always good to be on the same page when it comes to patient care.
We have a lot of people who are excited to attend the conference. It's for us to network and to, again, just, understand the information, understand the conversations and everything that we can do together. So we really are excited to see y'all at the end of the month.
Thank you, Chad. And when you do get your thoughts onto those slides and anything that we can use to refer to, just send it over and I'll share it with all of CMDA members.
Absolutely. Thank you.
Yeah, thank you. Next on our agenda are Doctors Julia Bellantoni and Tais Protasio. Both of these physicians are geriatric fellows at the University of Colorado. They were both part of the Pulp Med Futures program this year, which is a program for up-and-coming early career geriatric providers interested in post-acute and long-term care medicine. CMDA sponsors this program along with other the PALTC Foundation, and we're really glad to have these 2 participants who joined the program come back to CMDA here in Colorado and tell us a little bit about the conference. Thanks for sharing your slides, and thanks for being on our call today.
Excellent. Thanks so much, Dr. Pallett. Hopefully you guys are seeing the slides okay.
We are.
Excellent. All right. So I'm Julia and this is Tais, and we're both geriatric medicine fellows at CU, and attended the Pulp Med conference a few weeks ago in Charlotte and wanted to share some of our highlights from the conference. First, as Dr. Pallett mentioned, the Futures program that we both participated in and really enjoyed as sort of the kickoff to the conference for us. Our big highlights were first, just the opportunity to meet other geriatric fellows across the country. I think just being in a one-year clinical fellowship, it's hard to get outside of our own institution. So it was a really nice opportunity to network, to learn about other fellowships and sort of their career plans in post-acute and long-term care as well. Second was a big part of the program was to understand and learn about different career opportunities across different post-acute and long-term care settings. And I think the Futures program did a great job of bringing people from across the spectrum of different facilities across the country to give us really the down and dirty of what it is to work in post-acute and long-term care and help inspire us for our own careers.
I agree with everything Julia said. Should I put my video as well? Yeah, perfect. Can you guys hear me? I think so. Can you hear me? Okay. So apart from, meeting a lot of other fellows, this was really fun. And
It's a little hard to hear you now.
And other opportunities.
So let's switch. Sorry, this was our challenge of being together. I'll mute on my side.
Yeah.
And
At first there was the echo. The echo's gone now, but it was a little hard to hear.
Can you hear me now?
Yes.
All right. I wanted to share a little bit about the cases that we discusses and kind of a couple of things that I learned during those presentations, mostly kind of new things. We discussed different cases, some polypharmacy and deep prescribing opportunities to learn about these things throughout cases. And there was a case about trauma-informed care, so different ones, but a couple of clinical pearls that I brought to you. One was, one study was mentioned talking about GLP-1s and their effects not only on, what we know, diabetes and weight loss, but possibly also reducing risk of substance use and psychotic disorders, seizures, as well as Alzheimer's disease. This was a retrospective study, and this is kind of new data published in 2025, so still to be reevaluated, but something for us to be mindful of and continue to watch. Another case talked about a decision about deactivating an ICD at end of life, and when would be a good time for us to have this decision. Sometimes this is something that we may not bring to mind kind of until later into end of life, and maybe harder to do in terms of coordinating care with cardiologists, which ideally, if we can do earlier on in the disease, that can be done, coordinate with the whole team, and the ICD deactivation can be done earlier through cardiology. But another option that they also presented would be using a medical magnet. And I'm not sure if this is something that can, if it's something that the facilities provide, I would love to hear from you. But just kind of placing a magnet over the ICD, this kind of medical magnet, can also can deactivate the defibrillator part of it and not the pacing part of the pacemaker or the device. So it's something that we can use as kind of last resort if the patients are at end of life and we haven't been able to discontinue earlier on.
all right, and another big highlight of the conference was the year in review, which goes over sort of the sentinel research articles that were published this year in post-acute and long-term care. And I'll kind of breeze through these, but these were some of our favorite articles that were presented. The first was a study looking at older adults transferred to the emergency department from long-term care facilities for fall-related injuries. And it found that patients on oral anticoagulants did not have an increased risk of 30-day post-fall mortality. And actually care utilization was pretty similar in the two groups, including head imaging as well as discharge back to long-term care. Another study looked at statin therapies in older adults 75 years and older who are often not included in a lot of the cardiovascular research, but did find that they had a reduced cardiovascular disease and all-cause mortality without increasing the risk of severe adverse effects. And this benefit was shown to be consistent in the older population, those 85 years and older. An interesting study that I'll note did not include participants from long-term care, but still I think relevant to our population in general, looked at chronic and new anxiety being associated with increased risk of all-cause dementia, and interestingly found that patients who had treated anxiety had a reduction in their risk of all-cause dementia, similar to sort of the baseline risk of dementia for people who have never had anxiety. And then finally, there were a couple of articles focusing on zoledronic acid and denosumab, and found that zoledronic acid sequential therapy after denosumab discontinuation does not fully prevent the bone mineral density reduction, and particularly at the lumbar spine, there was still reduction in the density there when patients were transferred onto zoledronic acid. But they noted that being on denosumab for long periods of time, and particularly 3 years and longer, was associated with even further decreased bone mineral density. And so I think the story is not fully finished here on what the recommendations are for discontinuing denosumab and transferring therapies, but it was pretty clear that being on denosumab for extended period of times may be detrimental for bone mineral density in the long run.
We also participated in this session about, it was called Breaking Science, and just brought some new research studies that were kind of going through the last year to be presented by their primary investigators. We brought a couple of them. The first one is this one called Factors Influencing Intent to Leave Among Staff in 25 Nursing Homes. It was done by an epidemiologist at the Emory University, and really evaluated incivility, sorry, that's a hard word for me, burnout and resilience. And that study showed that 36% of all nursing staff, they actually evaluated 25 nursing homes, more than 900 staff members and providers. 50% of those staff were CNAs, and around a third were nurses, RNs. 36% of the staff actually reported an intent to leave, and 35% reported feeling burnt out. And actually, the experience of incivility was very common, experienced by about 50% of staff members. The other study we wanted to prevent was this one around meaningful activity engagement. It was evaluated in assisted living residents with dementia. It was a pilot study evaluating different steps to increase meaningful activity engagement in these patients with dementia in assisted living facilities. It had different steps to try to engage participants in more meaningful activities. First, they evaluated the environment and the policy of the places of these assisted living facilities. They did staff education and evaluated residents' preferences for meaningful activity, which for that they developed, they used a tool they actually developed first and was published in JAMDA not too long ago as well. And then they mentored the staff and to motivate the residents and staff to continue to be engaged in meaningful activity. For this study, in terms of engagement in meaningful activity, we saw that after 4 months, the participants tended to have less engagement with as you can see here with the blue line, and engagement in meaningful activity was stable after 4 months. Quality of life tended to increase a little bit after 4 months in the treatment arm of the study, and decreased a little bit in the control part of the study. And then the main goal was to evaluate behavioral symptoms, which was done by a questionnaire, and that tended to increase in the control arm versus decrease in the treatment arm. So it's something interesting to think about implementing in our facilities as well.
Another session that was of personal interest to mine was one on value-based care. And this set a really nice framework for sort of understanding the transition from pure fee-for-service to a full population-based payment model, and particularly applying that in the post-acute and long-term care setting. All of this aligning with sort of CMS's strategic vision that all Medicare beneficiaries will be part of a value-based care arrangement by the year 2030. I like that this sort of big overview of value-based care showed what that looks like on the spectrum, again, from category 1 on the far left all the way to category 4. I think this was a nice presentation to sort of understand the nuts and bolts on a high level of value-based care. And then another highlight of the conference was the policy session, in particular, several different panels as part of this session, one on health information exchange. It brought together clinicians, researchers, and technologists to talk about really the challenges in health information exchange across the continuum of care, and especially in post-acute and long-term care. Essentially that we need better information exchange across these silos of healthcare delivery. And my big takeaway, I think, from the session was that there is a lot of variability in the types and the capabilities of technology and the informatics that we use in different facilities. And that though it's very complicated, like this graphic shows on the right, there are a lot of different components to the EHR and information exchange, but the technology and the capabilities really are out there and are possible. We just need to better understand and incorporate clinical workflows in order to improve their usability and interoperability across different facilities. So I think the take-home message was that we need better partnerships between clinicians and technologists to improve health information exchange.
And lastly, I just wanted to touch base on this other lecture I attended about point of care ultrasound in applications for post-acute and long-term care. It's more of kind of food for thought. A couple of things that they presented is that we now don't have a lot of information on the use of POCUS or bedside point of care ultrasound, bedside point of care ultrasound in post-acute and long-term care. But it's actually a great opportunity, especially as more recent trainees are requiring to have more learning in POCUS during their training. It is something that can really be time saving and money saving as well, and can give us kind of really fast information. So especially for those patients that may not want to go to the emergency room, for example, we can help us make decisions around a lot of things in terms of fluid overload or pneumonia or cholelithiasis, and kind of different cases that they also presented, and something that we can consider having more information and training as well in this setting to kind of provide better care in the future in our facilities. This is all we had.
Thank you. I attended the same conference, and it's fun to see that conference from earlier this month through your eyes. Yeah. Thank you for preparing that for us. You mentioned one thing about the magnets for deactivating the ICDs. I can only speak from my experience. When we've needed it in the long-term care facility, we would ask our friendly hospice nurse if their company had a magnet. And sometimes the company would have one that all the nurses could share, and they could bring it to the facility for us to use. All right, questions or comments before we move on to our next speaker?
Regarding the study about staff turnover, was it just that they were identifying the causes, or did they have any solutions? So like these uncivil events, is it just that people have so many options to go from different places to places, or could you speak on that? Was there anything more there? It's a major issue at almost all my facilities.
This study was mostly an epidemiologic study, so trying to kind of understand the cause. They had questionnaires that they shared with the nursing staff. So really didn't really propose any specific plans to change what we're seeing.
Thank you.
Thanks, Dr. Plachta. We definitely see that as well. All right, well, appreciate that discussion. Dr. Reitman, do you have a quick question?
Yeah, I just got on. What was the name of the conference?
It was the PALTC 25 conference, the annual conference of the Post-Acute Long-Term Care Medical Association.
Okay, thank you.
Yeah, thank you. Well, our next speaker, Dr. J. Tillman, is the National Optum Psychiatric Medical Director. He has over 20 years of experience providing psychiatric care in a variety of settings, including long-term care and assisted living facilities. And we were just talking with Chad about the importance of having that conversation with the medical director and our surveyors. Well, let's hear what Dr. Tillman has to say.
Thank you, Sing. I'm going to share my screen and hope it works. People seeing
I see it.
essentially okay, the cover. A bird, good. Then I'm on the right track. Okay, very good. Well, thank you for having me speak today. I do serve as National Behavioral Health Medical Director and work with Sing, and was asked to talk about psychotropic medications and chemical restraints and generally the F-tag F605. So I'll provide an overview of F605 and then speak about three aspects of it. And these are a brief framework for helping determine if a psychotropic medication is a chemical restraint, when one might bypass non-pharmacologic approaches and move straight to using psychotropic medications. And lastly, a mention about gradual dose reductions, also known as GDRs. It's really refreshing to have to hear that you have state surveyors collaborating with your medical society. This is fantastic. I wish we had that in Connecticut when I was practicing. The guidance for F605 is impressive. It reads like a best practices manual for the treatment of behavioral health conditions in long-term care. It's comprehensive, and it establishes a solid baseline standard for mental health care. It's very welcome and will improve the lives of our patients. Okay. So this is essentially what F605 is about. I obviously won't cover every aspect of it. I've organized it into 6 broad points that roughly occur in the same order as prescribing. So the first 4 of these concerns are prior to medication initiation. The 5th is about when prescribing, and the 6th one is relevant for after prescribing. All require some form of documentation in the medical record. So to be clear, we're talking about treating distressing symptoms and behaviors in nursing home residents. And by distressing, that means that the person is trying to communicate something, an unmet need, discomfort, or thoughts they may not be able to express. These expressions, which we often call symptoms and behaviors, can include things like crying, apathy, or withdrawal. They can also show up as verbal or physical actions like pacing, cursing, hitting, kicking, pushing, scratching, tearing things, grabbing others. So number 1, non-pharm first means that before starting a psychotropic medication, we've tried non-pharmacologic approaches, also referred to as behavioral interventions. Number 2, the medication can't be used as a chemical restraint. I'll go into that into more detail about that shortly, about how to determine that. Number 3, indication. So there has to be a clear medical reason to prescribe the medication. That means a diagnosis, yes, but also documentation of target symptoms. The diagnosis alone isn't sufficient. Number 4, risks and consent. So there must be documentation that the patient or their medical decision maker was informed about the risks and benefits and that they agreed to the medication. So once you've obtained the green light to start a medication, the next part, number 5, is dose, duration, and GDR. The prescription should align with FDA indications. the manufacturer's recommendations, current standards of practice, the evidence base, something that supports our clinical reasoning. Ideally, gradual dose reductions must be attempted, and I'll talk more about that in a bit. And then lastly, number 6, there should be ongoing monitoring, both for side effects and for whether the medication is working. This can involve formal rating scales, but it could also be a line and a progress note. All right, so next I'll talk about chemical restraints. Okay. Now, when it comes to sedating medications, when is one considered to be a chemical restraint, and when is a sedating medication, sometimes the same medication, considered to be appropriate treatment? So to keep the theme of 6 going, there are 6 questions to ask oneself or keep in mind to help guide that determination. I didn't include issues of consent and monitoring, as those also apply to non-sedating psychotropic medications. The underlying principle is that chemical restraints are about control. Appropriate psychopharmacology is about treatment. But if the answer to any of these questions is no, then the medication could very well be a chemical restraint, meaning, again, its use is for control and not treatment. If the answer is yes, but there's no supporting documentation, it may be considered a chemical restraint. So let's go through them. So, number 1, are there documented target symptoms or behaviors? If so, they must be specific and well documented. Quote unquote, agitation, behaviors, sundowning are not acceptable. The diagnosis itself is not acceptable. Risperidone for dementia it's not going to fly. A better example would be, say, the patient has screaming and fist pounding. Those are more specific target symptoms, and then one can move on to the next question. And that is, do these symptoms or behaviors present a danger to the patient or others, or cause distress for the patient? Risk, I think we all understand. It just needs to be documented. Distress, I talked about how the guideline defines distress: attempts to communicate an unmet need, discomfort, or thoughts patients may not be able to express that manifest in the variety of ways I mentioned. Sometimes we're urged to medicate symptoms experienced by patients that are more distressing to the staff than they are to the patient. There's an interesting condition called Charles-Bonnet syndrome, in which patients with vision loss experience visual hallucinations. But usually these hallucinations are non-psychotic because they're not associated with a psychotic disorder. They're neutral and non-bizarre, and patients have insight into the fact they're not real, and there are no associated delusions. Now, not always, but much more often than not, in my experience, staff is more concerned that the patient is, for instance, seeing people in the room than the patient is. So adding an antipsychotic to treat these hallucinations in this context could be a chemical restraint. And number 3, have non-pharmacologic approaches been attempted first, and have they either not alleviated or only partially alleviated the risk or distress? So there are countless reasons that expressions of distress emerge, and there are even more potential environmental modifications, as well as essentially environmental modifications and behavioral approaches that can be used to alleviate these. If these are documented and the symptoms and behaviors persist, medication used to treat the cause of the distress is usually considered to be appropriate treatment. And number 4, is there a documented psychiatric diagnosis that accounts for the symptoms or behaviors? For F605, this diagnosis must be present, but alone, it's insufficient. Now, with these 6 questions, we've already covered the other half, target behaviors, in the first question. So what would fail this question? Quetiapine for adjustment disorder with anxiety would probably be a fail. Antipsychotics should never be used to treat adjustment disorder. If a patient's symptoms are severe enough to warrant an antipsychotic, then a more accurate and appropriate diagnosis should be identified, the one that truly explains the need for that level of intervention. And number 5, does the chosen medication treat the underlying psychiatric diagnosis, or is it merely a temporary solution such as benzodiazepines, trazodone, or hydroxyzine? And this can be a little tricky. These medications have their place, but in our population, they don't treat the underlying reason for most distressing symptoms. An analogy would be certain uses of acetaminophen. It's all right to use acetaminophen for the distressing symptoms of fever once the cause of the fever is known and the appropriate antibiotic is started. It's not all right to use acetaminophen before the cause of the fever is known. So if a patient with dementia is irritable and lashes out at staff due to depression, trazodone will not treat the depression. It can be used as a bridge until antidepressants are effective. It can help with specific breakthrough symptoms when antidepressant therapy isn't fully effective. And when it's used in these ways, it's important to document the risks and benefits in clinical rationale. I'm not mentioning benzodiazepines because their use in our population ideally should be minimized to special cases like end of life. And I'm not mentioning hydroxyzine because personally, I think they have nearly no use in our population. All right, and number 6, is the medication choice and dose appropriate? Again, that's based on current standards of care, evidence-based medicine, and the clinical presentation. Is Haldol, for instance, an appropriate choice of medication for a patient who doesn't have a psychotic disorder, but who uses racial slurs towards staff? Probably not. Is quetiapine 300 milligrams twice daily for a patient with dementia who exhibits high frequency disruptive screaming a chemical restraint? Well, if the patient's screaming is driven by psychosis, say in the context of Parkinson's disease, and the patient has displayed benefits from each dose increase until they reached 300 milligrams twice daily, and that's documented, is quetiapine a chemical restraint? I'd say no. If that dose in a different patient where a minimal attempt was made at determining what caused the screaming, and the patient essentially sleeps 20 hours a day, then quetiapine would be a chemical restraint. If the answer to all 6 of these questions is yes, and there's documentation and clinical rationale documented, then we can be more comfortable that a medication is for treatment and is not a chemical restraint. All right, I'm going to shift gears and move on and ask, so this is interesting. The F605 guidance reads, the intent of these requirements is to ensure residents only receive psychotropic medications when other non-pharmacological interventions are clinically contraindicated. But when would feasible and previously effective non-pharmacologic interventions be clinically contraindicated? So there are scenarios where there's a potential for non-pharmacologic approaches to delay treatment, and that delay would result in jeopardizing the patient's safety, well-being, or recovery. These scenarios are present when risk and severity are high, And I'll explain with a few examples of that. The imminent risk to self or others. These do require a clinical judgment of severity, and any of these examples could preclude treatment in place. But if it's felt, for example, that a patient was experiencing intense suicidal ideation without a plan, was too distressed to engage in or utilize a previously effective behavioral approach, say, for instance, journaling or listening to music, bypassing those approaches and going directly to a psychotropic medication with the intent of preventing an escalation or undue suffering would be warranted. It's not all or nothing, though. We would still want to modify the environment in helpful ways, even if it was felt that these wouldn't be fully effective and a psychotropic medication was used early. For instance, reducing stimuli could still help minimize distress and might allow for a lower dose of psychotropic medications. Some of you might be wondering, which psychotropic medications should we use in this situation? Lorazepam, hydroxyzine, trazodone. What can we use? I haven't heard of anyone using esketamine in long-term care just yet. Well, just as we need to document why we're going straight to a psychotropic, we also need to document the clinical rationale for the specific medication we choose. Whether a medication itself is appropriate depends more on the clinical context than on the medication itself. If the rationale for using lorazepam makes clinical sense in this particular case, then it could be appropriate to use. So severe distress, whether due to intense hallucinations or intense delusions, is essentially the same story. And when severe behavioral symptoms are driven by a medical issue and cause hyperactive delirium, patients by definition cannot attend and thus cannot engage in meaningful, active, non-pharmacologic approaches. We need to keep the patient safe with a psychotropic medication intervention while the underlying etiology of the delirium is identified and corrected. And we still want to modify the environment in ways that are helpful in delirium. Delirium is a great mimic. The patients with delirium can present like all the other examples on this page. All right, lastly, I wanted to address gradual dose reductions. So this is what the CMS guidance says. Residents who use psychotropic drugs receive gradual dose reductions in an effort to discontinue these drugs. Now, for some reason, an important part of this guidance, which I also left out, is ignored or discounted. So unless clinically contraindicated, we don't want to use these three words as a way to avoid doing any GDRs, but if a GDR is felt to be contraindicated, it does not have to be implemented. The pharmacy request to assess whether a GDR is indicated is not a mandate to actually attempt the GDR. At Optum, I host National Behavioral Health Office Hours where cases are presented to me from across the country. At least a couple of times a month, there are cases where there's an ill-advised GDR that was attempted that resulted in a significant decompensation, often requiring an inpatient level of care. A couple of weeks ago, an APRN presented a case where the embedded psychiatric consultant felt compelled to start a GDR on a geriatric patient with schizophrenia who was on antipsychotic monotherapy. They GDR'd as antipsychotic to discontinuation over 1 month. Then after about 3 weeks, the patient became floridly psychotic and required his first inpatient hospitalization in almost a decade. It's very unfortunate and avoidable. I spoke last year at the Post-Acute and Long-Term Care Conference about a framework for GDR decision-making. I'll briefly review some of the factors that may make a GDR, quote unquote, clinically contraindicated. When feasible, documenting these factors can justify avoiding risky GDRs and help prevent these kinds of unfortunate outcomes. All right, so I'll focus on the red box on the right in each of these slides. The color red, like a warning about potentially not attempting a GDR. In the framework, there are psychiatric illness factors, which are on this slide, and medication regimen factors and psychosocial factors on the upcoming slides. And these can help us decide whether or not to attempt a gradual dose reduction. So with regard to illness factors, and in that right box, chronic remitting disorders, think schizophrenia, recurrent MDD versus single episode depression, short duration of current remission. So it may not be time for a GDR just yet. Multiple past episodes. Again, think about recurrent versus single episode major depressive disorder. High severity decompensations. You know, if past recurrences of MDD in a patient are at most moderate, that's a different picture than someone whose depression recurrences result in long hospitalizations and potentially psychosis. Extensive family histories. Genetic loading often correlates with more severe illness and increases the risk of a GDR, potentially beyond the benefits of the GDR. So there are medication regimen factors that make us potentially less likely to want a GDR. So dual purpose medications, those are valuable. For instance, a patient on duloxetine for depression or anxiety and neuropathic pain. Perhaps we would not want to GDR that. Multiple past failed adequate therapeutic trials means the current medication may be the only medication that worked in this patient. You may not want to touch that. Difficult to achieve remission on current regimen. So in a sense, don't break what's not broken when it may take a long time to put the pieces back together. And I think naturally, intolerance of past GDR attempts. All right. And then psychosocial factors, again, on the right. If the presence of, if it's possible to identify the presence of the original stressor, if that's still present, or there's an emergence of new ones, then reducing or eliminating the medication may simply just result in a recurrence of depression, for instance. We want to be more careful about that. Sometimes the original stressor actually resolves and it makes it more permissive to do a GDR. So lack of access or ability to utilize psychotherapeutic modalities. Neurotransmitters are not the only mediators of mental illness, but when other mediators cannot be modified, like psychotherapy, we tend to lean more on the medications. So, weak social support systems and adverse childhood experience, history of those, unaddressed trauma. If those are present, we may want to not GDR a medication in that patient. Simply, we need to document these and put them in our clinical rationale. I just want to emphasize that it is not mandatory that the actual GDR take place, as long as it's documented why one is not taking place. All right, and that concludes that for me. I leave a little bit of time for questions if there are any.
Thank you for that very practical presentation, especially tying it right to our regulations. Dr. Reitman?
What do you think about the Elijah McClain case? Forgetting ketamine, that's off the table right now. Ketamine, I guess, is just used in some clinics for depression. But, what constitutes agitated delirium? Like in Colorado, supposedly that diagnosis has been scrubbed from the books because it's so ambiguous and non-medical people use it to justify dangerous things, like 3 cops on one person,
Yeah.
breaking their arm. This
Hmm.
is where social determinants of health play a role. But is that true that the diagnosis of agitated delirium is in question in Colorado?
That I'm not certain about that in Colorado specifically. It, you know, diagnoses and the way phenomena are viewed do change. That's true. The patients don't change, and so they still have the same issues and the same, same response to delirium. I guess my response to that would be to perhaps be more vigilant about exactly what is being treated.
I
I
think
don't
it's
know if
an
that
interesting.
answers the question, but again, patients don't change, but our way of viewing them may change simply to avoid unnecessary medication or over medication.
One question you didn't answer, that's my last question, is when do you have to call the cops? When do you call security agent? Sometimes you never know what you're going to get. Somebody who's well trained in de-escalation, and you didn't talk about de-escalation as one of the non-pharmacologic things. You did mention some techniques, but the technique isn't like giving a pill. Some people are really well trained. Some
Yes.
people just say, it works for my kids, if I hold them on the bed for a while. So
Right.
I think the training of the staff in de-escalation varies considerably. And is there a standard for that?
Yeah, that it does vary considerably, and I don't know that there's a specific standard for it, but in homes where that's valued, they tend to be more successful. It's like a whole different topic about de-escalation and the principles of that, but valuing that education is critical. And I agree that it is absolutely necessary.
There's someone with the hand raised, SPR.
Yes, hi, Dr. Tillman. Thank you so much. That was very helpful. I do have, a patient or two with my long-term care population that, they've been with our facility for some time. They choose to be mostly bedbound, very minimally active, with the activities that are offered to them. They complain of a lot of insomnia, difficulty falling asleep. We've been monitoring them with the sleep hours. They say that they can't sleep mostly during the nighttime. They have a lot of, sleep hours, charted during the daytime. We've tried different things, starting from melatonin, then tried other things like very low dose mirtazapine, and now they are, trialed on trazodone. My trazodone gets triggered for GDR often, and despite having tried all of these things, their sleep habits remain the same, where they are still awake a lot during the nighttime. They're still sleeping, in their bed a lot during the daytime. So then the discussion usually comes, if these people are still sleeping a lot during the day, then do they need to be taken off of their sleep aids? whatever that they are? Do we need to GDR and take them off of their sleep aid, sleep medications, whatever it is, and that they are just going to be in these habits of theirs no matter what? And then when I follow these GDR decision-making things that we come through, sometimes it is with those things where chronicity and the remitting diagnosis, the fact that we have tried them on multiple things, the fact that this is what, that they've fallen into. They've been on these things for many things, and this is just where they've fallen. It's kind of like the decision-making becomes kind of hard.
Yes.
Where do I fall with that?
Yeah. Yeah, it's difficult. I think one of the things you want to look back on is something specific to the patient. In this patient, was there a history of working third shift? I mean, is this something that's going to be difficult to reverse? I always ask that question because sometimes surprisingly we find out that was the case.
Yeah, I have a few patients, and it's not necessarily that it's a third shift thing, but I think a lot of it is just that that's been their chronic habit. Like they'll say for 20 years now or 30 years now, this is just what I've always done. Like I stay up, throughout the night or whatever. I watch TV or I do this or that. And it's because their spouse used to work, third shift or whatever. So they would stay up late until their spouse would come home, and, they would spend time with them, and then they would, go to sleep with them early in the morning, or, different things like that. Or that no matter what I do, this is just the way it is. My body always only falls asleep at like 3 o'clock in the morning. And then, I don't wake up until 11, 12 in the morning, or, and they say this is the only thing that has worked for me, or whether no matter what I do,
We are at the top
I
of
need
the
it.
hour. Yeah, Dr. Reddy, we are at the top of the hour.
Yeah, okay, sorry.
Appreciate your
Do you want
question.
to quickly answer that, or do?
Yeah, we would love a response.
Okay,
Sure.
just
Yeah,
that if
and I'm sorry to
if
cut
you're
you off.
No,
Time.
if you're trying to medicate something and it's just ineffective, and then you're basically only getting the risk. So if you're treating someone for just like intractable insomnia, that's really not distressing, but potentially bothersome to staff. Really what you end up doing is you medicate and increase the risk of falls, both when they're medicated and during the day. So sometimes you just have to, if it's an unsuccessful medication regimen, you have to start subtracting. And again, if it's not distressing to the patient, this is their home, and I get it. Third shift likes to have patients tucked in, but it's patient-centered care, and that's it's their home, and that's the way they should be managed, allowing them to stay up.
Okay.
Tough situation, though.
It is a tough situation.
Myself.
It is. You get a lot of pressure to medicate things like that.
Yeah. Okay. Thank you.
Thank you, Dr. Reddy. And thank you, Dr. Tillman. We really appreciate your presentation. If those are slides that you'd be comfortable sharing, I'd love to send it out to the CMDA members. Well, thank you all for joining our meeting today. Forgot what we're doing. We're meeting. And if you get a chance, please register for the CMDA annual conference. It's very easy. You just go to cmda.us. You can click on what kind of registration you want to do. Are you doing individual? Are you more with a group? We consider people with 10 or more as part of a group. It's on April 25 in person at the Denver PPA Center. Thank you so much for joining us, and we will see you next time.
Thanks so much, everyone.